right up here. Hi, everyone. Good morning. So this is really a topic that I'm very passionate about. I'm a breast medical oncologist, but it's also a lot to put in 20 minutes. How can we talk about all of cancer survivorship? So I'm going to choose to focus on you can see the outline here, the topics that patients are asking about, things that are really hot right now in the news, in the clinic, the things that really impact our patients on a day-to-day basis. So we'll talk about menopause and hormones because that is top of mind for a lot of people. We're going to talk about the genitourinary syndrome of menopause. We're going to talk about hot flashes, joint pain, sarcopenia, actually, sorry, the mental health I had to cut out because it was too much to cover, but I'm happy to answer any questions about that. So why is this important, right? This was in the news just this week. The 2026 cancer survival statistics are out, and 70% of patients are surviving for more than 5 years. Now, this is putting all cancers together, and now, 5 years is not, we want a lot more, but this is a pretty significant milestone. But what happens is as patients are living, now they're dealing with all the long-term side effects of the treatment that we gave them. And we have to think about how to help them live their healthiest lifestyle. And that's what they want to know. They want to know how are they not just surviving after a cancer diagnosis, but really thriving. So let's talk about menopause, right? Does anyone feel like that? Because I think our patients are feeling like this every day. They have no idea what they're doing. The messaging in the media is all over the place. But why is this important? And so the big thing is that, a lot of times we think about menopause as hot flashes, but it's really much more than that. There are a number of physiologic shifts that occur that happen in menopause. And really, again, we have the short-term side effects of things like hot flashes and night sweats that though can linger for a long time. But patients are getting loss of muscle mass. They're getting visceral fat gain. There's an increased risk of metabolic syndrome, and the majority of Americans are not metabolically healthy. So now we're just adding to this. There's an increased risk for cardiovascular disease, bone loss, osteoporosis, fracture risk, cognitive impairment, mental health, and the list goes on and on. So our patients are dealing with this, but they're also dealing with all of these side effects as a side effect of cancer treatment, of chemotherapy, of endocrine therapy. A lot of them are going into premature menopause through ovarian suppression and chemotherapy. And so now a lot of these side effects are compounded. And patients share in numerous ways in different studies that they are not prepared, that they have no idea what's coming. They're seeing all this in the media and they're scared. And then there's also a little bit of a lack of acknowledgement about what's to come and how difficult it is. And they find a really hard time getting support through the process. And a lot of them, because, hormone therapy is really, relatively not recommended for the hormone receptor positive patients, they find themselves excluded from the conversation because the conversation's all about hormones. And they're like, well, I can't have them, so how am I going to be supported? And so that's really where I think we can help and guide some of that conversation. So why does this matter? So this was a study published this year in the Menopause Journal, and they surveyed a number of patients that are breast cancer survivors in the United Kingdom, and they asked them, how much have your menopausal symptoms after breast cancer impacted your quality of life, your ability to work, your relationships? And you can see, so they asked them to score 1 through 6, and so the goes from left to right, the majority of patients are affected in terms of quality of life, work, and relationships. So this is really a significant thing. And again, this is in the UK, so we'll extrapolate, but nearly 3/4 of patients had less than 10 minutes allocated to discussing their menopause-related health concerns. So imagine, how do you do this in less than 10 minutes? And of course, it makes sense. We have 15-minute appointments. We have so much to cover, but this is what's happening. So as we think about menopausal hormone therapy and breast cancer risk, I adapted this slide from a great presentation at the San Antonio Breast Cancer Symposium from Dr. Lesberg, King, and Larkin. And really, as we think about who can have or who is a candidate for menopausal hormone therapy, we start with the lowest risk patients. Those are people, and I won't go into this in too much detail, but those are patients that have a family history of breast cancer, that maybe have a genetic mutation and are previvors, patients that have kind of benign but high-risk lesions, atypical hyperplasia, lobular carcinoma in situ, ductal carcinoma in situ. And then we move into the low to intermediate, which are patients with hormone receptor negative breast cancer. And then the higher risk, of course, is those with hormone receptor positive breast cancer, increasing risk from stage 1 to stage 4. So as we think about this, when patients are coming in and they're saying, can I have hormones? What can we talk about this? I like to think about them in those categories. And it helps patients, I think, understand too where they fall into the risk. So this is hot off the press. It was presented at the San Antonio Breast Cancer Symposium, and it's looking at an menopausal hormone therapy for patients who have BRCA mutations. And we've known that we can use hormone therapy in this group, but this was a really good study. They looked at over 600 women who, all these women had intact breast tissue. So 600 plus women who were BRCA mutation carriers who went on menopausal hormone therapy, and over 600 patients who did not go on menopausal hormone therapy. They had no prior breast cancer and they had their breast tissue intact. And what they found was that the ones who used menopausal hormone therapy had a lower incidence of developing breast cancer than those who didn't. Now remember, this is a group that has up to an 80% risk of getting breast cancer, so very high risk population. And 87 cases of breast cancer in the group that used menopausal hormone therapy compared to 128 cases in the group that did not. And this decrease in the incidence was mostly driven by patients who are using estrogen alone menopausal hormone therapy, but estrogen and progesterone did not increase the risk. And this is important because a lot of the data really suggests it's progesterone that drives the breast cancer risk and not the estrogen. And then there's a formulation of menopausal hormone therapy called Duovy, which uses a combo of estrogen and basidoxifene, which is a SERM, and it works as an anti-estrogen in the breast and uterus. And none of the patients that use Duovy developed breast cancer. So as we think about a personal history of hormone receptor negative breast cancer, we have not a lot of data, but the data that we do have does not show an increase in the risk of recurrence. And we feel more comfortable using menopausal hormone therapy in this group, but a lot of questions remain about when, when do we start? Do we start 2 years after diagnosis? Most people feel more comfortable as they kind of get to that 5-year mark where the risk of recurrence is lower. But this is where there's, a little bit more comfort. And then when we move to the hormone receptor positive group, we have good, decent, but old data saying that there is an increased risk of recurrence or developing a second breast cancer in patients who've had hormone receptor positive breast cancer. And we again think that the magnitude of the increase is really dependent on what their risk of recurrence is to begin with. So someone that has a 5 millimeter cancer 20 years ago is very different than somebody who had a 5 centimeter cancer with 5 positive lymph nodes. So, the conversation is starting to change. And this is a trial that is planned starting in the UK, but will be open, I believe, in the US as well. It's called the MENO-ABC trial. And the idea behind this trial is to really say, look, we know our patients are asking for this. We know that they are interested in going on menopausal hormone therapy. And some people are saying, I know I have a risk of recurrence, but I can't live like this. I am miserable. And so the idea with this trial is actually there's some patients that will be randomized and others that will just be enrolled. So we at least can study the patients that are doing this. Because right now we all have patients that are going on menopausal hormone therapy, but we have no way of collecting the data. So we actually don't know what's happening in modern times. All the data we have is 25 years old. So let's move on a little bit to the genitourinary syndrome of menopause. This is a big issue. So what happens in our patients on endocrine therapy who've gone through menopause is that they end up with decreased estrogen to the vulva and the vagina, and that makes tissues thinner, drier, more fragile. And symptoms include anything from dryness to burning to irritation to pain to frequent UTIs. I can't tell you the number of patients that are seeing urology for frequent urinary tract infections, but really a lot of this stems from decreased estrogen. So we actually did a study called the WISH Breast Study where we surveyed over 1,000 patients and asked them, what's going on with your sexual health? Who talked to you about it? What symptoms do you have? And you can see here that table here, just these are most frequent sexual health symptoms, including starting with decreased interest in sex, nearly 90% of patients, nearly 80% vaginal dryness, decreased lubrication, decreased arousal, and on it goes. So this is a huge, huge issue. And what's interesting is that patients are getting really mixed messages about vaginal hormones. You can see some of the comments there, but the bottom line is they're completely lost. Someone saying, yes, you can have vaginal estrogen. Someone saying, no, you can't. And they're like, where do I fit in? And because currently we're removing the label, but I have prescribed vaginal hormones to my patients, and then they've gone to pick them up and have been told, no, you can't have it because the label says contraindicated in breast cancer. So this is a huge issue and our patients are suffering. But the data is that our patients can use vaginal estrogen. These are guidelines from the American Urologic Association that support the use of local, low-dose vaginal estrogen. It's small amounts. It's a very low dose formulation. And that is also supported from ASCO, from the American College of Obstetrics and Gynecology, from NCCN. So this is something that we can and should be offering to our patients, or at least supporting if you don't feel comfortable prescribing. And the data is, there's a number of studies, but the bottom line, I won't go through all of these, but the bottom line is that there is no increase in the risk of death from breast cancer when using vaginal estrogen. Where a lot of people hesitate was that there was one study in 2022 that said if you use aromatase inhibitors, you have a higher risk of recurrence when on vaginal estrogen. And so that has really set us back a lot because people are very reluctant to prescribe because of that study. But when you look at the data, so first of all, in that study, they actually had patients on menopausal hormone therapy, systemic therapy, and they had no increase in the risk of recurrence, but vaginal estrogen did, right? So already we're kind of like, how does this make any sense? But the caveats to this data is they use much higher doses of vaginal estrogen than we use right now. So that's a big piece of it. We have no idea whether patients were compliant. We have no idea what stage treatment they got. And the majority of people in the cohort that they studied were on tamoxifen. So we think that the people on AIs were actually kind of a higher risk population to begin with that may have had a higher risk of recurrence to begin with. So that data, when you look at in the context of all the data we have, that's just one isolated study. All the other studies really support using vaginal estrogen. Moving on to vasomotor symptoms. So, hot flashes are really, they're debilitating for our patients. They're much more than a nuisance. We know that there's a change in the brain's temperature regulation, and in a low estrogen state, the thermoregulatory system is really sensitive to minor temperature increases. And so patients, and in menopausal women, they are much more likely to react to even smaller temperature changes compared to premenopausal women. Now, the big thing is that these hot flashes and night sweats, they lead to chronic health conditions. There's a number of studies showing that patients have higher cardiovascular risk with having hot flashes, and a lot of it is probably the downstream effects. They're not sleeping, they're not waking up, their inflammatory system is probably all over the place. That may impact their diet and exercise. So it's probably multifactorial, but it also leads to insulin resistance, disrupted sleep, higher pain severity, and poor mental health, right? So what happens is this may also lead our patients to have to discontinue endocrine therapy if they are having all of these symptoms. And so it's really a big, big problem. And then, of course, there's a number of factors that can worsen vasomotor symptoms, including smoking, stress, mental health issues, caffeine, heavy alcohol use. So it all kind of plays together. So what can we do? I won't go through all of these, but this is kind of how I approach it with my patients. So thinking about non-pharmacologic options, which, have some data. And for mild hot flashes, it can be helpful. So thinking of, starting with low-hanging fruit, right? Behavioral modification, exercise is huge. There's some data for acupuncture and other integrative therapies. There was a study a couple of years ago looking at a low-fat vegan diet with soy, and because of that phytoestrogen piece, and soy is good, fine to eat, and our patients did have the patients had a lower incidence of hot flashes. Supplements do nothing. The supplement industry is huge. They do nothing. There's a number of them out there, and the data is really inconclusive, or that it doesn't work. And then the other thing is that many over-the-counter supplements have high levels of phytoestrogen. So while we're fine with that in diet, we want to be careful not to include that in the supplements. And then in terms of the pharmacologic options, we have a number of drugs available. So there's a number of medications we've used off-label for a really long time. Antidepressants like venlafaxine, escitalopram, number of anti-seizure and nerve pain medications, oxybutynin, clonidine. But we have this new class of medications called neurokinin receptor antagonists, and these are they're specifically approved to treat vasomotor symptoms. They're non-hormonal, and this is the first drug that we have specifically approved for vasomotor symptoms compared to something that we're using off-label. And so these are the two drugs that are available right now. There's fezolinetant and elinzanetant, and these are both medications that are available. They can reduce hot flash frequency and severity. Fezolinetant has been around for about 2-3 years now, and it does have a black box warning for hepatotoxicity. It's rare, but it can happen, and so we do have to monitor liver enzymes. Side effects that are reported include abdominal pain, diarrhea, insomnia, but I will say most people do not have these side effects, and they experience such a drastic improvement in their hot flashes. The Highlight 1 trial is looking at using fezolinetant in patients with stage 0 to 3 breast cancer on endocrine therapy, because there's been a lot of criticism that we haven't studied these medications in patients with breast cancer. And then elinzanetant was recently approved, and the graph on the table on the right is from the OASIS 4 trial, and elinzanetant actually has published data in patients with breast cancer. And so that's the graph from there, and they showed that greater than 70% of patients treated with 12 weeks with elinzanetant had at least a 50% improvement in their vasomotor symptoms. And elinzanetant also does not have the black box warning for liver function. We do have to monitor liver enzymes, but it's much less common. So these are things that are great options. And elinzanetant may also help with sleep. So I've been kind of increasingly using that medication because we're thinking it can help both with the hot flashes and the sleep. Lastly, I'll talk about the aromatase inhibitor-associated musculoskeletal syndrome. And so anyone who takes care of any patients with aromatase inhibitors know that joint pain is a huge issue. And this is really a constellation of symptoms. So joint pain, muscle pain, joint stiffness, tendinopathy. And the reason that this happens, again, aromatase inhibitors lower estrogen levels, and we're in patients that are already low, and this leads to inflammation, impact on cartilage, altered pain perception, decreased lubrication. You can also see things like frozen shoulder, carpal tunnel syndrome, rotator cuff injuries. And it occurs in up to half of women on aromatase inhibitors, but the incidence may be higher, and this really can lead to non-adherence. There's a lot of questions about whether SERDs, if they are approved, will help with this. In the lidERA trial presented at San Antonio, there was a slightly lower incidence of discontinuation of the SERDs due to joint pain, so that's promising. And you can see there's a number of risk factors, but the bottom line is if people are newly in menopause and they're really just adjusting to that drop in estrogen, that's where they tend to have more symptoms. And then, of course, don't forget about bone health. So many patients are not getting regular bone density scans, and they are at high risk for osteoporosis and fractures, so we should be aware and monitoring and treating it. So what are some treatment options? There's a number available, but the bottom line is starting with medication adjustments. Taking a short holiday can help, switching aromatase inhibitors, switching to tamoxifen. And then we can think about medications that may work. I try not to use steroids long-term. Short-term use can be an option. I try to avoid long-term use of NSAIDs and Tylenol or long-term use of opioids as well, because that's not really helpful to managing these symptoms. There is some duloxetine benefit, so that's an option. And then when we think about supplements here, there is a little bit of benefit. So you may see some benefit for glucosamine, chondroitin, tart cherry, and omega-3 fatty acids. Vitamin D is not recommended solely for this purpose, and there is some data for curcumin in osteoarthritis, but we don't have data, looking at it specifically for aromatase inhibitor joint pain. And then site-directed therapy, so a number of patients find benefit from steroid injections or splints or carpal tunnel release, things like that. And then complementary approaches and exercise. I put them on the bottom, but they're honestly the most important: movement. And I know it's hard to tell a patient who's really miserable and struggling, you should go out and exercise, but something slow, 5-10 minutes, low impact can really help. It actually can increase, body fluid and circulation, and so they actually feel better when they do exercise. And then as well, things like acupuncture, PT, OT, massage, all can be very helpful. And, as we think about this, lastly, I want to mention sarcopenia. So sarcopenia is a progressive loss of muscle mass, strength, and then physical performance. And you can diagnose it by not your standard bone density scan that many places have, but some bone density scans can actually measure muscle mass. And then there's a number of these BIA scales. You might have a smart scale at home that tells you this information, and then clinics have things like an in-body scale that really measures it. And the thing that's important is that muscle mass starts to decrease about 0.5 to 1% per year, starting at the age of 45, and then accelerates much further after 65 and after 75. And so now we're, thinking about our patients. Skeletal muscle atrophy has been reported after one dose of chemotherapy. So now we're, and I was always trained to look at weight, right? So I'd have patients come into the clinic and we were like, oh, you're on chemo and you didn't lose any weight. Great job. But really what's happening is that they're losing muscle mass and they're gaining fat mass. So their body composition is completely altered with chemotherapy, and we're not monitoring it. And this is important because sarcopenia is associated with worse clinical outcomes, poor prognosis, higher risk of depression, treatment delays, dose reduction, higher risk of endocrine therapy discontinuation, and side effects. And the rates of sarcopenia are as high as 30 to 40% in our patients, and even higher in metastatic breast cancer. And lastly, it's also associated with insulin resistance and type 2 diabetes and metabolic syndrome. So, I think as we start to really move into this kind of new era where we're really focusing on our patient survivorship a lot, this is a huge issue that I think is a really untapped field, because it can really help us understand what's happening to our patients with their body composition and then how to guide them individually. So in conclusion, cancer survivorship is an active phase of care. It really requires proactive management. I couldn't touch on all the things, but I hope this gave you a little bit of flavor of what's out there. And there's a lot that we can do. There's a lot of evidence out there, still a lot of gaps, but I hope that our patients are really being supported and that we can refer them to the appropriate people. We can't treat all of this as oncologists, but we can utilize everyone to help us. And thank you.
Thank you, Dr. Teplinsky. Okay, we're now going to take a quick break for breakfast. If you can please head to the exhibitor room, grab some breakfast at the buffet, and come back here in about 15 minutes for a working session from Pfizer.